welcome everyone. Welcome to those joining us online tonight, and welcome to those who will be watching this at a later date. My name is Anneliese. I'm one of the co-chairs of the Dermatology Special Interest Group for WONCA. Just before we get started, a little bit of housekeeping. First of all, just checking everyone's in the right place. We are having a discussion tonight on pearls and wisdom and reflections from this year's Australian College of Dermatologists annual scientific meeting, which was held in Melbourne recently. Just before we begin, a couple of housekeeping points. Please keep yourself muted. I'm just going to keep adding people while we're going. Please keep yourself muted when you're not speaking. Feel free to pop questions into the chat throughout the session. I'll be monitoring this and we'll leave some time for discussion at the end. And what we're doing this time is this is intended to be quite a relaxed and conversational session rather than a formal lecture. I am really excited about the night that we have ahead of us, particularly as I am an Australian-based special interest GP, and I am really looking forward to hearing about these reflections from the conference. Given I am based on Australian land and so is Rochelle, it is customary for us to start with what we call an acknowledgement of country. And through this, what I want to do is just acknowledge the lands from which I am presenting today, which is the lands of the Wurundjeri people from the Kulin Nation, as I am based in Melbourne, and extend my respects to any First Nations clinicians who might be joining us today, and acknowledge pay my respects to elders both past and present. Rochelle, I believe that you are presenting from, is it Gadigal land?
That's correct, Annalise.
Fantastic. And if anyone else is based in Australia or in countries around the world where this is a custom, I would encourage you to add these details into the chat and we can know where everyone is presenting from. I am also quite interested where everyone's joining us from today. So if you'd like to say hi in the chat and just introduce yourself and say where you are zooming in from today, that would be fantastic. So, what I might do is I might actually formally introduce Rochelle. Now, Rochelle, I may butcher the pronunciation, but I seem to remember you are Dr. Rochelle Oei-Hicks. Is that correct? Fantastic.
That's perfect.
So Rochelle is a first-year dermatology trainee, but will be known to many joining us as coming from a general practice background until very recently. She is one of our I've gone blank on the word. What is it? Key members, founding members of the Special Interest Group in Dermatology. And she's a fellow of the Royal Australian College of General Practitioners. Rochelle is passionate about education, collaborative care, and improving access to dermatologic care across Australia. And I might even say across the world, particularly in regional and rural communities. Rochelle has previously been involved with RACGP, so the Royal Australian College of General Practitioners, as both a GP supervisor, so supervising trainees, and with the University of New South Wales as a co-joint associate lecturer. Alongside clinical practice, she's involved in clinical research with the University of Sydney and has contributed to advisory committees for the Kids Research Institute in WA and the National Centre for Immunisation Research and Surveillance. And she is particularly passionate about strengthening partnerships between dermatologists and primary care, such as general practice workforce, to improve dermatological care, health literacy, and patient outcomes. So we feel the royal we, feel incredibly lucky to have one of our members go on to become a dermatologist in training. I think one of the reasons I'm so excited about this is I think historically there have been some silos, so almost some separation between, I guess, primary care and dermatology care. And I really see Rochelle is starting to bridge that gap as she continues to work through her training. So I am so excited. So we're going to start with a couple of questions for Rochelle, and then Rochelle is going to share some slides on what she's learned. And as anyone has any chats while we're going? Oh, and I can see I am struggling to see a few things. Oh, so we've got Janelle from Ireland, WA. We've got Carl and Theta in orange. Fantastic. Okay, so Rochelle, can you start by explaining, for those of us who haven't attended before, what actually is the Australian College of Dermatologists annual scientific meeting?
Well, firstly, thank you so much for the warm welcome, Anneliese, and for inviting me to come and speak to everyone tonight. And thank you for joining us. I know we've got a small group, but hopefully it means that we can have a nice conversation and chat. So basically, as you've explained, Anneliese, it's the College of Dermatologists annual conference, basically. And so it takes place on Friday. Normally we have workshops, and then Saturday, Sunday, Monday are full of great talks and presentations from speakers from mostly Australia, but around the world.
Fantastic. And I was wondering, how many people attend the conference? Is it quite a small one or relatively large?
This was actually the biggest turnout we've had so far, apparently. So we had 1,800 people there, which is very exciting. There's also a conference that takes place at the same time for all of the dermatology nurses from around Australia as well.
Cool. And I'm really curious, having attended a lot of, I've attended a online version of the conference during COVID, which I'm sure is quite different to in person. But I have also attended a lot of general practice and medical educator conferences. I'm just curious, how how is a dermatology conference different to, for example, a WONCA conference or general practice conference?
That's an excellent question, and I may not actually be the best person to answer that because unfortunately I haven't managed to attend a Wonka conference, although I would love to in the future. But I think they would be very similar. I think, there's lots of sessions that are run often concurrently, and people can pick and choose what interests them. There's also often lots of great food, so morning tea, lunch, afternoon tea, and so there are really good breaks and lots of coffee and tea for people in between. One of the big differences might be we have a really big exhibition hall at the dermatology conferences, where there are obviously lots of brands from around the world selling or trying to promote their products or devices to doctors and nurses. So that might be one of the slight differences. But I think on the whole, maybe the other difference would be different target audience for content.
Yeah.
So very much focused at maybe practicing dermatologists and not even necessarily at registrars such as myself.
Wow. And I think just anecdotally, one of the things I've noticed attending some of these conferences is with general practice conferences, I've noticed that often people are very casually dressed. I remember a few conferences in Australia, people have been wearing flip-flops around and
Yep.
wearing like board shorts and t-shirts, whereas my experiences with my small experiences, everyone has been really a little bit more dressed up and well put together. Is that perhaps accurate? Everyone is usually wearing something kind of clinical practice like.
Yes, definitely more professional work clothes, probably.
Yeah.
Except maybe on
Yeah.
Sunday, people might rock up in jeans and kind of smart casual.
Sure, sure. And I was just wondering, what was the overall mood or direction of this year's meeting?
Mm. So there was a really big focus on, I guess, some of the key issues being faced around the world, particularly in the, I guess, dermatology space. So there was a lot of focus on photo protection, especially for those coming from Australia. A lot of people would know that there's a lot of misinformation around sunscreens in particular. And so that was one of the big focuses of the conference. And another big topic was improving access to dermatologic care for the rest of the world and particularly underserved populations. So there was a big focus on skin of color as well.
Fantastic. I'm looking forward to asking you a few more questions about that later. Um, so we might shift over just to some more kind of general questions. to start with. Having just attended, I think was this your first time attending this particular type of conference? Second.
Second.
And were there any was there anything that really surprised you that either in terms of emerging evidence or shifts in expert opinion?
Mm. I think one of the amazing things about a lot of the dermatologists that spoke is a lot of them are speaking from personal experience or more anecdotal experience. And so a lot of them were sharing tips and tricks that have worked for them in their clinical practice, but they might not yet be well established or published yet. So that was quite interesting, hearing some of their insights and just seeing how creative and innovative a lot of the specialists are. And I think that
Fantastic.
would probably go with lots of the different doctors around the world as well.
Yeah, cool. Can you think of any, I might be putting you on the spot, but can you think of any example?
So there was in particular Psoriasis rubra pilaris.
Yeah.
We no, I might have said that wrong. Uh, I might have said the condition wrong. I've been learning a lot of different terms of
Yeah.
lots of
Yeah.
different
Yeah.
conditions. Um, but there's been some trials of the use of sirolimus topically for the
Oh,
treatment
cool.
of this condition.
Hmm.
So together with using quite strong pulses of laser. Some of the dermatologists were saying that using sirolimus topically had actually
Hmm.
improved the appearance of the flushing that often comes with this condition. I think actually
Ah,
keratosis pilaris rubra, I think is the
yeah.
condition.
Yeah.
Yeah. Um,
And
so that was quite interesting.
I actually do know a little bit about sirolimus. A
Yeah.
number of years ago, I worked in a organ transplant clinic alongside a number of dermatologists, and a lot of our patients were on sirolimus or tacrolimus. And from
Mm.
putting my general practice hat on for a moment, I have come across requests for sirolimus with the push for longevity or anti-aging medications. Um, it's not something I feel comfortable prescribing for anti-aging, but I know that there are other GPs who do prescribe it for that reason. So, very interesting space at the moment. And
Yes, absolutely.
now, was there a particular talk or session that really stood out to you that really changed the way that you think about your clinical practice?
Mm. I think in particular, I was really struck by the clinical pearls given by some of the really well-established dermatologists, just sharing kind of some of their thoughts, and that was quite inspiring for me, hearing from people that have been in the field for a really long time. So learning some of their tips and tricks was wonderful. One of the dermatologist, Dr. Belinda Welsh, in particular,
No,
she showed
Belinda
a
well.
picture. Yeah,
Yeah.
Belinda's one, well, wonderful educator. She showed a photo of one of her patients' necks. In particular, the patient was concerned about poikiloderma of Sabat, which often, I guess, we see sort of blotchy pigmentation and vessel damage, so telangiectasia. And this lady also had a big goiter, which the patient
Mm.
actually wasn't concerned about and hadn't really thought much about. So when Dr. Welsh mentioned it, the patient thought, oh, I just thought my neck was getting a little bit fat. And that was a really good reminder that we're doctors first and foremost. So no matter where or what your practice looks like. So I know that many of us are family practitioners or GPs, but some of us might be kind of more specialized in a certain area, that we're still doctors first and foremost. So I thought that was a really good tip for me, and to not ever lose the GP in me.
Oh, fantastic. Cool. And I know, I think you're going to go through some slides in a little bit, but I was wondering if there was any updates that you think are particularly important for GPs to know about.
Yes, absolutely. So one of the things that I'm really looking forward to seeing maybe change in the next little while, it hasn't yet been published fully, but there's been a lot of talk about potentially downgrading the guidelines for management of melanoma. So, as many of you would be aware, currently the guidelines are often for something like melanoma in situ to do a wide local excision of sort of 5 to 10 millimeters. Um, or, if it's a little bit more invasive, thinking about sort of 1 to 2 centimeter margins. There's now a bit of talk about whether or not the recurrence rates actually change, or whether when we go back for those wider re-excisions, whether there's actually any cells left. And so in the next little while, there might be a change that we're actually just seeking clearance and not going back for wide local excisions. So that's something that will actually, I guess, improve our workflow, that we might not need to bring patients back as much. They won't need to go through a bigger excision or a second excision. And that will also have savings for healthcare as well.
Oh, fantastic. That's really interesting. And just so I understand it better, and maybe for anyone joining us this online, when you're saying clearance, are we talking just clear of margins, like to the nth part of a millimeter, or like a 1 or 2 millimeter margin, or is it just still being
Mm.
discussed?
That's a really good question. So I guess normally if we are trying to do something like an excision biopsy, we try and
Mm.
recommend doing like a 2 millimeter margin. So something like that would probably be appropriate, and not trying to get sort of 5 to 7 millimeter clearance.
Cool. And moving on to another question, you touched on skin of color and photo protection as being recurring themes. I was wondering if you could tell us a little bit more about these and why you think these conversations are becoming increasingly important for discussion in conferences such as these.
Mm. I think in particular, the photo protection, we're seeing um, that I guess it's becoming a bit of a public health issue, particularly with lots of misinformation out there, people being concerned about sunscreens being toxic, but also emerging evidence, which I'll talk about shortly, about the role of long UVA and visible light in conditions such as melasma, and pigmentation, as well as causing photo aging changes. So I think that's one of the reasons that photo protection probably came up a lot. We also have the benefit of having Professor Henry Lim, who is one of the leading experts in photo protection, and he's based in the US. So that was probably another reason that we focused quite a bit on photo protection. We were also really fortunate that a lot of the organisers of the ASM play a special role in the International League of Dermatologic Societies. So, Professor Lim is the current president of the ILDS, and Associate Professor Michelle Rodriguez was one of the conference organisers. And you would be familiar with Michelle Anneliese, but she, I guess, had a very keen interest in ensuring that we improve education around dermatologic conditions, particularly in skin of color, because often patients with skin of color are underrepresented in textbooks and teaching. So I think that was kind of something that that the conference aimed to improve.
Fantastic. I can't. I think we might have had a conversation recently. I teach medical students at Melbourne University, and I teach them about primary care dermatology, and I show a whole lot of different pictures on my slides. And one of the pictures I show one of um, uh, chronic plaque psoriasis. In a skin phototype, I think it's a four. I think it's a five. And then I show a picture of a slide of someone with impetigo in a skin phototype 6. And I think eventually someone will get the psoriasis one, a couple in the room of 50 or 60 students. but almost never does anyone get the impetigo diagnosis right. And I show a quite a classical, I say textbook, but I realize that we don't show these types of cases in textbooks. But I show a kind of discrete lesion with a golden crust on an ankle in a patient who's come in for an ultrasound guided steroid injection to their ankle with all of this impetigo there. And yeah, it's been really interesting hearing from the students as they reflect. We like I know impetigo, but I had no idea that was how it presented on that skin type. So I think it's really great that we're starting to make inroads in this area. Now, I might hand over to you to share your slides at this stage, but I'm just wondering from those who have joined us, do we have any questions at this stage, or shall we ask a few more questions later on? We've got no hands
Very
going up, so
happy.
I might let you I might let
Sounds
you
good.
share your slides now, and I'm going to mute myself and I'm going to disappear into the background.
And very happy at any point if anyone has a question to raise their hands or unmute themselves. So let me see if I can share my screen. Okay, can everyone see that? Hopefully, people
Yes,
can.
yes, you can.
Wonderful. Thanks, Anneliese. Okay, so basically tonight, thanks, Carl. Just wanting to share some of the key clinical pearls for primary care physicians. So hopefully this will be relevant for all of you. Um, so just a few disclosures. So I am a fellow of the Royal Australian College of General Practitioners, and I'm a first year advanced trainee. So basically just wanting to share that this is a summary of what I learned from leading experts, and I myself am not the expert. So I'm still learning, and hopefully you can learn with me too. So today I'll be going through a couple of updates. I think we've just had another person join us, so welcome. So just wanting to share a couple of updates about photoprotection, psoriasis, skin of color, rosacea, dermatitis, and social media. And I'll also be sharing some tips and tricks, in particular, focusing on biologics and immunotherapy and basically what the primary care physician needs to know and some other clinical pearls. And then we can have some time, hopefully, for some question and answer at the end. But please feel free to ask during the webinar at any stage as well. So a little bit about photoprotection. As many of you would already be familiar with, the role of UVA and UVB is very well established. However, there's sort of more emerging evidence suggesting that long UVA, between 240 to 400 nanometers in wavelength, is playing more of a role, particularly in tanning, photoaging, and photocarcinogenesis. And that applies to actually all skin types. And there's a little bit more evidence nowadays that visible light, approximately between 400 to 700 nanometers, is playing quite a big role in producing erythema in all skin types, as well as tanning for skin phototypes 4 to 6. So that's quite an interesting thing because often when we think about sunscreens, we're often thinking about UVA and UVB, mostly UVB being covered in SPF, and then the UVA being covered in the broad spectrum. So I guess that this is something that's a little bit new and we'll be seeing more of in the future.
Rochelle, could I? Oh,
In
you're already.
Yeah,
Oh no, you're. I might just quickly touch base for a moment.
yeah.
I didn't explain phototypes before. Would you mind
Mm.
just briefly explaining what we mean by skin phototypes?
Yeah, absolutely. So when we are talking about skin phototypes, it's also known as Fitzpatrick skin types. So we have sort of 1 to 6. I do actually have a diagram coming up shortly, but so hopefully that will make sense shortly. But one, normally we're talking about really fair skin types, often people with red hair and blue eyes might be often what we see, or green eyes. And then it kind of it's based on how someone also reacts to sunlight. So normally Fitzpatrick skin type 2 might be someone with blonde hair or light brown hair, and they often can sort of maybe when they get sun exposure, they might turn a little bit red or and go back to being fair, or they may sometimes tan, but very rarely. Whereas Fitzpatrick skin type 1 would be someone who burns pretty much instantly and will never ever tan. And that kind of goes down to Fitzpatrick skin type 6, and that might be someone with African American background who normally, when they get exposed to the sun, might not actually ever get burnt. But someone with sort of type 3 skin often would be someone who can tan quite gradually. So I've got a diagram coming up soon, but that's a great question, Anneliese. And it is definitely something useful for us to be familiar with, particularly when we're assessing people's risk. So that's kind of more assessing someone's actual response to sun. And often we do associate it with maybe someone's phenotype or what they look like. But that's also another topic that came up in skin of color. So happy to answer more questions on that shortly. So in particular with UVA1 or this long UVA and visible light, we can see that it plays a large role, especially in skin types 4 to 6. So looking at this diagram, you can see that with UVA1, there is actually a little bit of color change. And with visible light as well, we see a little bit of color change. Less so with Fitzpatrick or skin type 2 in this case. So often visible light maybe plays less of a role in lighter skin types. And this is especially important, the role of UVA1 and visible light in pigmentary disorders like melasma. In particular, some research done by Professor Henry Lim, or actually presented in his slides and done by another team, Coley et al., demonstrated that there's a synergistic effect between visible light and UVA1, or this long UVA. You can see here that the color change that's actually produced, or this sort of darkening and pigmentation, is actually heightened when there's the effect of both UVA1 and visible light. And so this brings us to, I guess, some emerging technology or new filters in sunscreens being used that are particularly targeted at visible light and UVA1. And there are actually some new sunscreen filters that target blue light as well, which has been shown to increase photoaging. So often when we're thinking about blocking visible light and UVA1, many of you might be familiar that tint in the form of iron oxide is often used in sunscreens, but that's not always sort of aesthetically acceptable for people. And so there's some newer filters, including a filter by La Roche-Posay called Mexoral 400. So this is an exciting time, and there will be some sort of newer filters emerging. Now onto skin of color, and this is where you can see the Fitzpatrick scale. So as I mentioned, there is this type 1 skin that we often talk about, and that's normally someone who always burns and never really tans. And just to highlight that, I guess the Fitzpatrick skin type, or the when we talk about this is actually talking about their response to sun and to UV radiation. So often it might be associated with what someone's skin looks like, but actually it's mostly highlighting someone's response to UV radiation. So this is particularly important in skin of color. So when we actually talk about skin of color, Professor Rodriguez mentioned that this term kind of is an umbrella term for all skin that is non-white or non-Caucasian. And so often we use it interchangeably with something like the Fitzpatrick skin type in order to describe what someone's skin might look like. However, this is, like I mentioned, just a tool to assess response to UV light exposure. And I'll be talking about a different tool that might be more useful for us to actually think about how we describe someone's skin color. So as we discussed, there is a gross lack of representation in textbooks as well as medical education, as Anneliese has highlighted, and also an underrepresentation of patients with skin of color in clinical trials. So this is the newer tool that has been developed by L.S. Monk, who's actually a sociologist, and adopted by Google AI. So they've developed something called the Monk Skin Tone Scale, and this is actually shows 10 different categories of skin tone, and this might be a better tool for us to actually categorize people's skin color. This is now being available in different swatches, and you can actually put it up against patient skin to assess which skin type or skin tone someone has. And I didn't get to check out the website too much myself, but there's a link here. And I believe you can actually figure out your skin tone online. So that's a new cool thing that Google AI has developed. So now for those amongst us who might be using lasers for patients in skin of color, or treating patients in skin of color. I'm not sure if anyone here actually does any laser treatments, but it's especially important for us to consider the risk of post-inflammatory hyperpigmentation, or otherwise known as PIH. And in particular, one of the tips that Professor Rodriguez shared was being able to look at the palmar creases. And so in particular, we can see here that there's actually quite a difference between the color of the palmar creases and the surrounding skin. And this actually is a marker of, can be used as a risk predictor for whether someone might develop post-inflammatory hyperpigmentation, and then being extra careful if someone is doing any treatments, and particularly also, I guess, for thinking about how we assess someone's risk. And so really important when we're seeing a patient that we take a history about what happens when someone scars, whether or not they're prone to hyperpigmentation, asking about UV exposure and tanning and what happens to their skin, as well as asking about medications and prior treatment and outcomes. And so this is really helpful. You can see there's a 4-point visual scale, and it evaluates pigmentation contrast between palmar creases and surrounding skin. So if there's no difference, then that's low risk, as well as if they're scoring 1 or 2, and then scoring 2 or 3 kind of indicates that there might be a higher risk of developing post-inflammatory hyperpigmentation. And then moving on to psoriasis. So this kind of also touches on the topic of skin of color, but we talked about how psoriasis presents in diverse skin types. So in particular, I guess something that was really helpful is that psoriasis occurs in 1 to 3% of the world's population. So 3.7% white, 2% black, and 1.7% Hispanic. And in skin of color, it actually, there's evidence that shows that patients are 4 times more likely to require a biopsy to get a diagnosis, and it often takes them 3 times longer to get a diagnosis. Some research also showed that when dermatologists were surveyed, only about 66% said they weren't really comfortable diagnosing skin conditions in patients with skin of color. So that's quite interesting. So some of the diagnostic challenges, particularly for diagnosing psoriasis, is that there's a lot less erythema. There's also increased hyperpigmentation, post-inflammation. Often they have thicker, more scaly plaques and more scalp involvement. In particular, we spoke about the contribution of hair care regimes, and especially in Afro-textured hair. So often Afro-textured hair is a lot more fragile, and that might mean that people wash their hair a lot less frequently. And so we have to think really carefully when we prescribe different medications for the scalp about what might be acceptable for our patients if, in particular, they're washing their hair less frequently or their hair is a lot more fragile. So one of the tips that Professor Rodriguez gave was thinking about the base in which we put our actives. So there are lots of different medications that can be compounded, such as putting betamethasone dipropionate in olive oil. And so thinking about how we can actually make treatments more accessible and acceptable for our patients is helpful as well.
Just to interrupt for a moment, putting on my educator
Mm,
hat for a moment, with
yes.
afro textured hair, I presume that we're talking about quite I know a little bit about hair types, but I'm guessing
Mm,
that a lot of people watching this won't. With
mm,
afro textured hair, I understand that I always get them mixed up. They're quite flat when you look at them under the microscope, and therefore they curl a lot more, I think. We're talking about quite curly hair generally. Is that correct?
yes. Yes.
Yes.
Yes.
Okay.
And
So that
really
really
prone to
kind,
knots as
yeah,
well.
yeah. Fantastic. Sorry
Yeah.
to interrupt. I just want to make sure I'm following correctly.
No, thanks, Anneliese. Um, so as Anneliese was talking about how she often puts up photos for her medical students, these are some photos just of what psoriasis might look like in skin of color. So often we might see that psoriatic lesions are characterized by a purple or lilac tint, and more often gray as well. And that there might be thicker plaques as well as extensive scaling and hyper or hypopigmentation. In particular, one of the examples that Professor Rodriguez gave was that often people might present with hypopigmentation around the scalp region, and they might be referred in with vitiligo, but actually it could be that there was some hypopigmentation after having psoriasis, which is quite interesting. Um, so when we think about psoriasis in skin of color, so on the left side, we've got sort of two different types of psoriasis in what we deem as skin of color. And one of the tips that um, Michelle Rodriguez gave was thinking about replacing that purple or grey with pink or red. And then that's when we get our classic looking psoriasis that we're often taught about in textbooks. That coral coloured arrow was courtesy of my nephew who was helping me. He's 8 and he said that I needed to put the pink coral arrow to help hone in that that's what we're replacing the grey and that violaceous tint with. So also something that I found really interesting and probably have only learnt more about lately, some of you may know this already, but psoriasis is also particularly important in managing other comorbidities. So in particular, interleukin 23 is one of the pro-inflammatory pathways that drives psoriatic skin inflammation and atherosclerosis. And that psoriasis is actually an independent risk factor for cardiovascular disease. And so really, I guess when we're thinking about psoriasis, it's not just a skin condition. It actually does have impacts for the patient's overall health. So thinking about how, if someone presents with psoriasis, thinking about how we can manage their other risk factors, such as their cholesterol, their sugar levels, if they're a smoker, thinking about their pack years. And in particular, it's not something that in Australia is commonly or routinely done, but there is some discussion around whether or not this should actually be added into our regular screening is testing for lipoprotein A. So in particular, people of Southeast Asian descent, Indians and Sri Lankans actually have evidence that they're positive for lipoprotein A, and that can actually increase their cardiovascular risk. So that's just something to think about, especially in our patients who have psoriasis. Then we're going to move on to psoriasis in children. And I found this actually very interesting. So psoriasis affects 0.1 to 1% of children worldwide. And often when we're thinking about psoriasis, it's really helpful to think about the history of the patient in front of us or the child in front of us. So often cradle cap is the first presentation of psoriasis in a lot of patients. And it's often correlated with a nappy rash, which often presents as really bright red. So often, I guess, recurrent nappy rashes in kids is associated with psoriasis. And there are other associations with psoriasis in children, including obesity, sleep disturbance, mental health issues, joint issues, and bullying. And interestingly, obesity is often correlated with severity of psoriasis in children. Another thing to ask about on history taking is about family history. So 30 to 50% of children have a first degree relative with psoriasis. On examination, often it can appear quite a lot like atopic dermatitis or eczema, and they're often thinner or softer plaques. It's often not as well demarcated as psoriasis in adults, and there's often less scale and less erythema than in adults as well. It's also not classically that extensor surface. So normally, I guess in classic psoriasis, we think about, backs of elbows, backs of knees, or on the front of knees, but actually often more facial and flexural involvement, as well as scalp and periauricular regions are often involved. And pruritus is often very common, so really itchy skin. Carbonization is also quite common. So for those of you who might not completely understand the term carbonization, what that refers to is the appearance of new lesions on previously unaffected skin. And that normally is following an injury of any kind. So it could be after a surgery or a surgical site scar, or it could be a graze or a cut that sometimes then new psoriatic plaques can form. And often does involve about 30%, 38% have nail involvement as well. And the most common morphological type for kids is plaque psoriasis, and then guttate psoriasis. And pustular psoriasis is actually quite rare in children. Hi, Jackson. Thanks for joining us. So now a little bit about rosacea. So back in 2017, so a little bit ago, there has been a rosacea consensus, otherwise known as ROSCO, and it's kind of moved. It's something that's helpful for us to actually think about how we diagnose rosacea, given that it's often a clinical diagnosis. So this was something that I actually wasn't very familiar with, so I thought this might be helpful to share. But looking at sort of having one diagnostic feature of either phymatus changes, so that classic sort of rhinophyma that people develop or is associated with rosacea, or persistent centrofacial erythema with transient flushing, as well as two of these four major features, so papules and pustules, flushing, which is often frequent and prolonged, telangiectasia, which are these little fine vessels, and ocular manifestations. So that could involve lid margin telangiectasia, blepharitis, keratitis, conjunctivitis, sclerokeratitis, or anterior uveitis. And that someone might also have some minor features, but this isn't necessary for the diagnosis. So burning or stinging of the skin, edema, or dry sensation of the skin. This was one of the talks that was, or part of some of the clinical pearls provided by Professor Adrienne Lee. And this was about her approach to dermatitis. So often thinking about sort of the timing, whether it's more immediate or delayed when we're thinking about contact urticaria or allergic contact dermatitis or allergic or irritant contact dermatitis. We also think about the pattern and distribution of in which the dermatitis occurs, so whether it's on hands, face, eyelids, or neck. Particularly important to ask about occupation. So I guess hairdressers is a really common occupation that presents with hand dermatitis, as well as healthcare workers, and that might be to different soaps around the hospital or sanitizers. Thinking about exposure, so how long ago were they exposed to some sort of irritant or allergen, and then Professor Adrienne Lee sort of gave a different list of some various irritants and allergens to be aware of. So methyl isothiazolinone is one of the really common things that's often in shampoos or conditioners. So people might present with kind of some dermatitis around their forehead or ears, kind of from when they're washing their scalp, that it's sort of contacting those areas. Perfumes are also a big one. Nail cosmetics, particularly for eyelids. So a lot of people might present with eyelid dermatitis, and often that's due to contact. So in particular, acrylic, shellac, SNS, nail polish, and nail hardeners are some of the biggest culprits, and so important to ask about those. Hair dyes, airborne, so that could be, pollens or dust in the air can sometimes present as sort of an airborne dermatitis, and sunscreens can also cause some irritation and dermatitis. With sunscreens, it's quite tricky to work out, I guess, which ingredient might be causing it. Often it's not really the filters themselves, but it might be some of the other preservatives or fragrances added in. But it's very hard to test for patients. And so often it is sort of trial and error and working out if there's a common ingredient in some various sunscreens. And the management often involves avoidance, potentially desensitization if it's a more immediate allergy, or avoiding for a minimum of 6 weeks and then reintroducing one at a time. And then if wanting to do some further investigations, you might do an IgE if you're thinking about an allergy, or a RAS test. And then patch testing would be if you're looking at particular irritants and can't identify a cause, and that's more in the allergic contact dermatitis, so the delayed dermatitis. Sorry, this clicker's not working. So in terms of approach, management often is using topical corticosteroids to calm down the inflammation, and then can consider calcineurin inhibitors later on. But obviously avoidance is a really big thing if you can identify the cause. There are also quite a few new apps that have come out which can help patients identify ingredients in different cosmetic products. So there's Inky Decoder, CosDNA, and the Cosme app. And the Cosme app, I believe, has been established by a dermatologist from the Australasian College of Dermatologists. And so that's helpful for patients if they're trying to work out what ingredients and what products they can continue using if they've been diagnosed with some sort of allergic contact dermatitis. Now, this is a topic that's quite close to my heart, and I had the pleasure of presenting in this session. So we had a presentation in particular on social media, the good, the bad, and the ugly. So many of you might be aware that disinformation is the intentional spread of misinformation, and that this is becoming a big problem, particularly on social media. And the WHO has now classified misinformation as a public health issue. It does have real effects for, and particularly, I guess, might be politically driven. It's causing increases in infectious diseases, and some people are doing it for money and power, and that it's actually posing a risk to science and public health. So we've seen a reemergence of things like diphtheria, whooping cough, and measles, particularly with anti-vaccination movements, and that it's actually we're having the worst vaccine coverage in the past decade. So it's now at less than 90%. And in order to have herd immunity, we need a minimum of 95%. One of the things that was highlighted is that misinformation actually creates distrust in the health system and in establishments, and that the solution is systemic, but also at an individual level. So one of the key points was that we as health professionals are part of the solution, and that we need to help promote discernment in our patients, meet people where they're at and teach them about what is actually correct and what is evidence-based, and that we might be able to do some of that through mobilizing social networks and friends, and that we actually do need trusted health professionals to help build trust again. And so one of the things that can be quite helpful is pre-bunking misinformation. So actually spreading the right information and teaching our patients about what is correct. So, for example, if one of the things that I like to do is tell people about sunscreens and that they actually don't. One of the big myths online currently is that sunscreens cause cancer, and so actually telling them that the research shows that they actually prevent skin cancer. So I think helpful to use our roles as clinicians to help combat some of that misinformation. Many of you might also be online, whether in more of a public profile or just as people who use social media. But it is actually really important for us to be aware of what is being spread online in order to facilitate dialogue with our patients and engage with them with the things that they're seeing online as well. It is also really important, and this was what I spoke about, was that we need to be aware of our own legal and professional responsibilities, and that it's actually different in every country. So this will be an interesting space to watch in the future. Now, Anneliese, let me know how we're going for time, but I've got a couple more sort of updates.
I'm really enjoying it and I'm learning a lot. Do you think we'd be ready for questions in the next 5 minutes or so, or 5 to 7 minutes? Would that
Yeah.
work?
Yes, I will speed through this stuff and feel free to ask me at the end if I went over
Yeah.
anything too quickly. So this is very briefly biologics, kind of what primary care physicians need to know. So biologics is definitely a space that I'm very new to and haven't been doing much of up until learning about it recently as a trainee. But basically, biologics target specific immune pathways in order to bring about precise immune modulation. The monoclonal antibodies used are a Y-shaped protein with a variable binding site. And with the names, just so that guys are aware, the UMABs are 100% human, the ZUMABs are greater than 95% human, and the ZIMABs are chimeric, so approximately 65% human and partially mouse. And so commonly they're being used in atopic dermatitis, psoriasis, hidradenitis suppurativa, and chronic spontaneous urticaria. And there's lots of emerging uses sort of coming up and lots of exciting things happening in the biologics space. But other things that useful for primary care physicians to know is that often they need to be commenced by a rheumatologist, immunologist, or dermatologist. But in many countries, primary care physicians play a role in continuing these managements and so prescribing ongoingly. So screening is often performed initially at before commencing treatment. Screening done is around infections, so tuberculosis, hepatitis B, hepatitis C, HIV, and strongyloides. Often it's important to check someone's vaccinations are up to date. So all live vaccines need to be completed at least 4 weeks before starting treatment, and no live vaccines are to be given during treatment. Baseline bloods include sort of full blood count, EUC, LFTs, and these are often repeated depending on which agent is commenced. And sometimes an autoimmune screen might be performed, particularly if there's a history of autoimmune conditions or joint involvement in psoriasis. Importantly, counselling should be done regarding the risk of infection awareness, pregnancy planning, and malignancy history. This should be done by the prescriber, but GPs and family physicians do play a really important role in ensuring that these things don't get missed. So if you have a patient that has been commenced on a biologic, it might just be worth flagging this and making sure that it has been discussed. Other things to be aware of, sometimes these patients will be assessed at 12 to 16 weeks post-initiation and then every 24 weeks for continuation. But as primary care physicians, patients might present to you in the meantime, in between their checkups. And so it is really important to monitor for any adverse effects. And you might be able to perform some repeat bloods if required. So in particular, I like to think about local ocular infections, skin-related adverse effects, laboratory adverse effects or changes on blood tests, and then the more serious reactions that can occur, including anaphylaxis or allergic reactions, ocular, eye pain, and visual disturbance. Sometimes there's also new onset psoriasis and often musculoskeletal issues. So always just good to be aware of sort of that these treatments can cause various adverse effects and that you might be seeing them before they follow up with their specialist. So this I'll just very briefly touch on, but some people might see this term biosimilar. So sometimes people might be changed over to something called a biosimilar, which are basically identical copies of an original biologic, and they're assessed as safe and effective. They don't go through quite the same rigorous testing as initial biologics, but often they can be used very effectively to continue treating various conditions, and they're often a lot cheaper. So in terms of immunotherapy and what primary care physicians need to know, I guess one of the big things is that you might see patients with cutaneous toxicities. So often immunotherapy, I guess, sometimes used in things like managing melanoma or other cutaneous malignancies. People come in with things like eczema, lichenoid reactions, morbilliform eruptions, so it often looks like measles, pruritus, itch, acneiform eruptions, so things that look like acne or folliculitis, fungal skin infections, psoriasiform dermatitis, rosacea, bullous disease, or cutaneous T-cell lymphoma. Basically, with immunotherapy, any treatment that affects the immune system, patients can get any kind of condition. And so that's just something to be aware of when your patients might be on immunotherapy, and feeling free to reach out to their oncologist or dermatologist or whoever has initiated the immunotherapy if your patient is experiencing any odd side effects from treatment. I'm going to very rapidly go through some of the tips and tricks that I learned from some of the amazing dermatologists that spoke. So in particular, in the consultation, Professor Delova from South Africa talked about asking patients how their condition makes them feel. So she had these nouns written on little pebbles and stones that she collected from various places, and just being able to give her patients the words to describe how they're feeling when they might not be able to find it in their own vocabulary. She highlighted that it only really takes us 1 minute, but it can be really helpful for us to understand the impact that someone's condition has on them, not just skin, but other conditions. And it can be helpful in follow-up as well when a patient it can actually show that they're feeling so much better in and of themselves. And so this was one of her patients that actually is an artist and created her some special stones which had all the various nouns on them. Other tips and tricks is just thinking about medical gaslighting. So there are really high rates, particular in Ehlers-Danlos syndrome and endometriosis. And one of the tips that was given to us was thinking about how we explain to them the symptoms that they've got, the symptoms that they don't have, and the diagnostic criteria that they might need in order to reach a certain diagnosis. And that we actually, as physicians, need to give patients an honest and grounded alternative diagnosis. So rather than telling them that their condition is made up or it's all in their head, to actually think about, well, I don't know if you actually do have Ehlers-Danlos, but you might have hypermobility, and kind of thinking about how we don't strip away a patient's identity if that's kind of where they've been putting their hope in. And so I think that's really helpful for us, just thinking about the person as a whole, even if they might not present with all of the classic criteria for a diagnosis. Other things to think about is how we look at equality and equity. So this was really important for me. I've often kind of maybe thought they were the same thing, but that equality does not equal equity. So equity is about fair access, opportunity, and support, and how we can ensure that people around the world in particular are able to access and have equitable access to healthcare. When we think about referrals, something that I probably felt as a general practitioner was feeling that I had to have failed all possible treatments before referring on to a specialist or to the dermatologist, for example, and thrown lots of different creams at patients. But really, that we don't actually have to have completely tried everything or fixed our patient at any point if you're not really sure what the patient might have, to think about referring on or discussing with a specialist to kind of run a case past them. Think about whether, you know, there might be any feedback for us as clinicians and how we can improve our practice in the future. I guess also being aware that some conditions actually have better outcomes if they're treated early, such as vitiligo, for example. So referring on early actually often ends up with a better prognosis for patients as well. I've been triaging quite a lot of referrals to my dermatology department, and it's really helpful when family physicians and general practitioners provide as much information as possible to facilitate triage. So, for example, if you're able to biopsy lesions, that helps us, especially because wait times can be quite long. So, if there's anything you're particularly concerned about and it comes back as positive for melanoma or squamous cell cancer, it means that we can get them in a lot more rapidly. Actually using some of those morphological terms that we were taught in medical school of how to describe rashes can be really helpful as well. And providing photos if consent has been given by the patient. It's also very helpful to tell the treating team or specialist what your main concern is. For example, if you're worried that a spot looks like a melanoma, that's a lot more helpful than please assess for lesions of concern, particularly when we're trying to triage someone quite urgently. Now, this was more about the tips and tricks for the procedure room. This was a artwork or a video done by Maria Kojic, who is an artist, and she gathered or asked the surgeons to gather all the waste from her operation after being diagnosed with breast cancer in 2019. And this is just how much waste was actually produced during that operation. So surgery, interestingly, accounts for 30 to 70% of hospital waste. I'm sure that many of you do procedures in your clinics or practices, or some of you might even be hospital-based. And so there was an interesting review done by Fitzpatrick et al., which demonstrated that there was no difference in surgical site infection, length of stay, complications, or mortality using just disposable gloves. So clean gloves are actually 7 times cheaper and 10 times less carbon intensive than sterile gloves. And so there's a bit of a move towards just using clean disposable gloves rather than sterile gloves. There's also a tip of buffering local anesthetic with sodium bicarb. So sometimes just 10% sodium bicarb, which saves costs, but also uses less local anesthetic. And interesting, the NICE has come out with a guideline on using soap and water at the start of the procedure and then alcohol gel afterwards, which obviously saves on water. Some other tips and tricks post-op, particularly for those of us who perform procedures, that applying a Tegaderm post-op for 3 months afterwards can improve hypertrophic scarring and keloid scarring, as well as stop the scar from stretching, as often scars remodel for up to sort of 12 weeks after a procedure. And it's helpful for use in young patients, re-excisions of hypertrophic scars, previous history of in patients with previous history of hypertrophic or keloid scars, and high tension areas like the back or chest. You can also use paper tape, hyperfix, or silicone dressings. Um, and thank you for bearing with me. I definitely feel like the best part of the ASM, other than all of the amazing learning, was actually learning from and meeting so many inspiring colleagues in the field. So definitely would recommend people thinking about attending in the future. And please let me know if you're going to any of the ASMs in the future. And just a special thank you to some of the amazing professors and dermatologists who shared some of their slides with me. Questions. Sorry, that was like rapid fire, but
That was
hopefully
fantastic.
people found that useful.
I was wondering if anyone had any questions at this stage. Feel free to unmute yourself and ask, or you can just pop it into the chat. I have two questions, so I'm going to jump. Oh, we've got one in the chat already. Oh, Janelle, such a helpful talk. Yes, Janelle, I was thinking exactly the same thing. I thought this, I was really sad I couldn't make it to the conference, and I feel like I've learnt so much tonight. It's fantastic. Um, so I have a lot of patients who are using red light masks, and I am not a cosmetic doctor. And I know we've got red light, blue light, and infrared. And I know
Mm,
that from my limited education about cosmetics, I understand that a lot of dermal therapists are using blue light for acne management. And I'm
mm.
wondering, does that seem to be heading out the door, that particular use, or was there concern across infrared, like infrared saunas that patients are using, or red light masks as well? I don't know if you can answer that, but I'm just really curious.
Yeah, that's a great question. Unfortunately, I didn't hear any talks on this specific topic,
Yeah.
but Professor Lim did highlight that blue light does actually cause photoaging. So I guess
Mhm.
that's something to just be aware of it for those who are using blue light for acne management. Um, Other things that we do know from previous discussions that I've had with other dermatologists is that um, infrared, I guess that heat can actually worsen pigmentary disorders, particularly for the darker skin types. So for people who are prone to melasma, the heat in infrared saunas can actually worsen those things and pigmentation. So I think some of those things need to be used in caution, like with caution when people have particular conditions. But yeah, I unfortunately I don't know too much about all the other evidence around red light masks.
No worries. I was putting you on the spot there. I have one other question, and I'm thinking we'll wind up in the next couple of minutes. And I have come across a number of patients with allergic contact dermatitis over the years. And one of the questions I always get asked, especially when we're thinking about sunscreen allergy, is what should I use? And
Mm.
I was wondering, do you have, and I know you can't promote any particular brands, but I'm just wondering if would you use like a zinc-based sunscreen as an example, or you can mention just some names you might mention if that's help if you can think of any.
Yeah, yeah. So that's a really good question. So one of the great things that Professor Lim talked about was changing the way that we think about sunscreens. So there's often people will talk about chemical versus physical sunscreens, but the proper name should be really for chemical should be organic sunscreens and inorganic sunscreens. And when we talk about organic, it's mostly those chemical filters. So like previously oxybenzone, avobenzone, those sorts of, or now like the Mexoral 400 that La Roche-Posay has come out with. And then when we're talking about the inorganic filters, they're often considered the more physical blockers. So titanium dioxide, zinc oxide. Um, so often there is some discussion about whether those more physical or the inorganic might sit on top of the skin more often and cause less irritation. So, particularly, I guess, when people have breaks in the skin, people might prefer to use more of those zinc-based sunscreens. But often they're not as cosmetically appealing. So, um, they're using now nanoparticle sized zinc, which there's previously been some, I guess, uh, often people talk about the inorganic sunscreens or those physical blockers reflecting and scattering UV radiation instead of absorbing, which is how chemical sunscreens work. However, what we actually know is that about 60% of those physical sunscreens actually use absorption now. So we, yeah, I guess it's kind of people might need to do a bit of trial and error to figure out what sunscreens work for them. There's definitely sort of pros and cons in terms of um, ease of application for more of those nanoparticle sized zinc based or titanium based sunscreens. But it really depends, I guess, on what someone um, would like to use, as well as yeah, whether they've got underlying skin conditions. So I think what Professor Lim said was, sometimes he would recommend the sort of more inorganic sunscreens or those physical sunscreens if someone has eczema or broken skin.
Fantastic. I gave you a bit of a curly question then. I think that's all the questions from me. Now that I have put Rochelle on the spot, does anyone else have any questions from that presentation? Well, we might wrap up there. I think I can speak for everyone here that that was absolutely fantastic. And I was really looking forward to hearing your thoughts. And I really learned a lot. And I may have taken some sneaky screenshots that I'm looking forward to putting in my notes for my learning for later. Um, and I really particularly love that slide on approach to your kind of contact dermatitises and looking at timing and blood different testing and things like that. And that was a really helpful reminder for me. So let's wind up there. And thank you so much for your time. We really appreciate it. Fantastic. Awesome. I will leave you
Thanks,
all to your
Anneliese.
day/night. And thank you for joining us, everyone. See you later.
Yeah.
Awesome. Bye.
Thanks for joining us, everyone. Bye.